All right, we're going to go ahead and get started. Welcome. I'm Julie Haluska with Alliance One and the chair of the Education Webinar Committee for CAHAM. And I would like to introduce our speaker today. It's Debbie Binczewski. She has extensive background in healthcare finance and revenue cycle, both as a hospital executive and as a consultant. Presently, Debbie is the president of Uprise Consulting Group, who specializes in the increase of long-term sustainable net revenue for hospitals and clinics through root cause resolution of preventable denial. Debbie holds a BS in accounting from San Diego State University and an MBA from University of Phoenix. It's my pleasure to turn it over to Debbie.
Hi, thank you, Julie, and welcome everyone. I'm so glad you could attend today. Just quickly, a little bit of, as Julie mentioned that, but we specialize in eliminating the preventable denials with our robust and highly customizable and intuitive dashboard, along with our consulting team, which can be together or independently. So today we're going to talk about denials management. We're going to do it from a patient access approach. So we'll focus on access and tips and tools you can utilize for that. So let's go ahead and get started. Okay, there we go. So it's really the agenda, not objectives. We're going to take a look at denial statistical trends, just a basic understanding of our CARS codes. So some of this might be basic understanding for a lot of you, but we want to make sure that everybody is filled in. We'll also take a look at the top patient access denials, and then we'll go through a denials project template on what you guys can do at your organization to do a denials project to get at the root cause and resolution. And then we have a really quick case study at the end. I'm going to go ahead and ask you guys to hold your questions to the end, and then Julie will go ahead and start a Q&A session after that. So our denial statistics, these statistics come from Change Healthcare from their 2020 Revenue Cycle Denials Index report. They have their claims processor, so they have access to a lot of data, and they go ahead and publish this information. I believe it comes out annually, but it might be every other year. So overall, denials for healthcare are increasing. If we take a look at the chart in 2016, the national average of denials was 9%, and this is of gross revenue. Fast forward to 2019, the second half, it was up 0.5% to 9.5%. And in first quarter of 2020, in March, we start COVID and we start that disruption. It moves up to 10%. Second quarter of 2020, now a lot of things are closed down. Denials are now up to 10.8. A lot of things are going on. Remote work is kicking in, that type of thing. And then the last data for this report was third quarter 2020, and the national average of denials was up to 11.1%. And so what does that mean? The industry standard is to have your denials less than 4% of your gross charges. So at the end of third quarter 2020, we're almost twice that amount, well, actually 3 times the amount. Registration and eligibility denials account for about 20% of all the total denials. Hospitals write off 90% more claims than they did 6 years ago. And that's from advisory board, and I know advisory board's been filed. And then of the denials, 86% of all denials are potentially avoidable. We know as an industry, it's impossible to 0% denials. We have CMS changes rules, contracts change, so we'll never get there. They always change the rules on us. But we want to get as many we want to resolve as many denials at the root cause so we don't have them as possible. Of that 86% of denials that are potentially avoidable, 24% of those are non-recoverable. That means we've left that money for all of the great services and procedures that we did for our patients on the table. The health plans have that, and not us, our hospital. Just a quick little cartoon here. The operation was a success, and after another week or so of pleading, I'm confident I'll convince the HMO to pay for it. And so that's what we're working on. That's the landscape that we're doing. Quick overview of denial. I call them denial reason codes. The official name are CARS codes. Those are claim adjustment reason codes. These codes provide information on what the reason for the denial. And so these codes are standardized by HIPAA, and they come on your electronic remit files or your 835 files, and they tell you why that claim was paid differently. Currently, there's approximately 287 active CARS codes. Chances, it seems overwhelming and a lot, but chances are your hospital or system won't have anywhere near that. These codes are updated 3 times a year. And CMS has contracted with X12 to provide the maintenance of these codes. So they have a national code maintenance. That committee meets and determines the code. So if there's a denial reason code you would like added or one changed or modified, there's a form that you can fill out in writing and send it to X12. Next, we have our RARC codes, which are remittance advice codes. These provide additional information to the CARS code. So you'll see a CARS code on your electronic remit for the denial, and then it'll refer to another code, a RARC code, and that'll give you some additional information or more detailed. There are hundreds of RARC codes. These are updated 3 times per year, and these codes are maintained by CMS. So the top avoidable denials for the front end, registration and eligibility, as we mentioned earlier, is the top one. And those are plan coverage. So maybe we got the demographics incorrect, coordination of benefits. Maybe we had the secondary insurance paid for the first one. And one of the ones is copay. And people might not think of that as a denial, but we get that through that says, you know, you're denied $50 because you didn't collect your copay. And those are very informative for you guys if you have any upfront cash collection, so you can utilize that to help in that. Next, we have authorization and pre-certification. One of the top ones is that it's an invalid, and these will come in where physician offices will send over paperwork, you know, for lab tests or radiology or surgeries and that. And they often include a CPT code or an ICD-10 code. And our authorization staff will contact the payer and get that approved. Many times we find out that the physician's office or whoever's providing that paperwork has put down the wrong code, and our staff doesn't know that, so they authorize the incorrect code, and then we don't get paid for the services. Another one that comes up with authorization and pre-certification is denied. So our folks will go ahead and authorize or try to get the authorization. The insurance company will deny it for whatever reason, and then we have a breakdown in our process. It's not communicated to the patient possibly or the physician office, or maybe it has been communicated and our registration folks don't see it in the system. Whatever the case may be, the patient comes in for that particular service or procedure, has it done, and then we don't get paid for it because up front the insurance company told us that they weren't going to pay for it. And finally, we have exceeds. This happens a lot in therapies like OT, PT, speech. It'll also can happen in infusion centers and maybe chemo. And that's where we go ahead and get maybe 10 sessions authorized. And I have 10 PT sessions. I come in for my 11th session. Nobody's went to the insurance company to reauthorize. So I come in for the 11th, I get my PT done, we send out the claim, it gets denied because there's no authorization on it. And then finally, we have services not covered. A lot of times this might be informational, but it also could be an actual avoidable denial. When it could be it's not covered per the contract, and then it would be more informational. We should know that, but it's something that is happening and we need to take a look at. All right, so not only when we have a denial, do we leave money on the table? That's cash we're not getting in for our organization. We also have the soft costs and the rework costs. And the denial rework costs, to do a denial rework cost, it costs the provider approximately $118 per claim. So just by getting the denial back and having someone in the staff research it, correct it, rebill it, it's an average of $118 per claim. So it's very costly to the organization. So this is an example of an organization, and they had total denials of $20 million. So that's 100%. Currently, in their current landscape, they were getting paid $15 million or 75% via the rework process, and then 25% they were unable to recover, so they wrote off. So the leadership gets together and they strategically decide that they're going to put more bodies to help denials and get them recovered. So with that, their new goal is to get paid for 90% of their denials, or 18 million, and thereby reducing their write-offs 3 million down to 2 million, or 10%. While that's great and it's really helpful and it gets cash in the door, what that does is it keeps us on our denials hamster wheel. We're constantly running and sending out and correcting claims with the same issue, totally trying to grab that dollars that the health plans are withholding from us and saying, see if you can figure it out. And so we want to get off of that hamster wheel. So a different approach or way to look at the denials landscape is to resolve the denials at the root cause where they won't happen again. So here's the same hospital. They have 20 million in denials, but their focus has shifted. They're not going to put more bodies just to get the money in the door and the claim. They're going to take those resources and put teams together and figure out what the root cause is and resolve the root cause. And that'll move the total denials on an annual basis from 20 million down to 14 million. And that leaves means that $6 million that they would have prior tried to recover, that's going to be cash in the door. And that'll be reoccurring. You don't have to do anything. The claim goes out, the cash comes in. And not only do you get the cash in, but you're also saving inherent on those soft costs and FTE savings, that $118 that we looked at before. So it's a win-win for everyone. So it's just kind of focusing and shifting the focus on how you handle the denials. So to give you guys some tools to take back, we'll take a look at a denials project. And this is just a high-level template. Again, this is focused on patient access. So there's other things that can be done, like creating denials teams and that type of thing. But we're going to focus on patient access. So the first thing we want to do is we want to analyze our data. Then we're going to identify and target initiatives. From that, we're going to do our root cause resolution. And then we're going to do what we call relentlessly monitor. And that means that once we have an initiative implemented and we have the root cause resolved, we want to continuously monitor that to make sure that it doesn't slip out and we have a denials issue with it again. So it's for our long-term sustainability so we can keep that net revenue coming in. So first, let's take a look at data analysis. The first thing that you want to do is you want to collect all of your data. On the left-hand side, we have an Excel spreadsheet that will work very well. You want to get your date, you want your CARS code. I like having the description in there just because I don't want to look it up all the time, so it's helpful for me. You want the payer because you can scorecard payers with this, and you might find that Blue Cross is always denying a certain radiology claim, and then you can work with Blue Cross on that. Then the dollar amount of the claim and the patient ID so you can actually go and look at it. So that's your very simplistic one. The EHR systems, most of them have denials report in that. On the right-hand side, we have our Uprise denials dashboard that we utilize with our denials project. That's really robust. So anything in between, but it's important just to be able to have that data. So once you collect that data, you want to start reviewing the data. The first thing you're going to want to do is take your denial codes that you're getting denied for and categorize them. The three pretty much standardized categories are clinical, informational, and technical. Clinical are going to be your level of care, medical necessity, that type of thing. It's usually dealt with in case management and utilization review. I'm going to skip information. Let's go down to technical. Technical are ones that we can fix and typically send back in. Maybe demographic information is incorrect. Maybe it has the wrong CPT code. It went to the wrong biller, but it's information that we can correct. And most of the patient access one, I would say pretty much all of them, unless it's days denied, which crosses over with clinical, will be technical. Let's talk a little bit about informational. Informational are ones that provide information to us. Typically, informational denials are not true denials. I'll give you an example. One of the denials that comes through that's classified as informational is charges exceed contracted amount. So we know that what we get reimbursed is typically different than our charges. So great information, but it's not a true denial because we'll never get that money in. Why it's great information is you can take that and you can spot check or do an audit on different payers and see if they're paying in line with your contract or if there's some underpayment issues. After you've classified your denials, you're going to want to go in and identify the responsible party. So we're going to go ahead and identify these. And these could be very different in your facility depending on what your structure is. So we have departments like registration and billing, case management, utilization review. You have the charge master and HIM, so various departments on that. So once you've categorized your denials and you've identified the department, now you're ready to establish your baseline. We recommend a minimum of 3 months of denials, preferably 6. With COVID, everything is a little wacky, so it can be even up to 12 years, but a minimum of 3 months. So you're going to take these, and then you're going to utilize this data in reporting and trending. And it's really important to have that baseline, because as you go through the process of resolving the denials, now you can take your new denials and bump it up against the baseline and say, hey, I have decreased registration denials by 50%. And then we can quantify that and say yay to our executives. Next, we're going to identify and target our initiatives. So now we're going to take a look at our data and see what we can do with it. So I recommend first sorting the data by high dollar. This is important because this is going to get some big cash in the door. However, high dollar denials are typically low in volume. So pick 1 or 2 of those. And then go ahead and sort it by high volume. A lot of people don't do this, but your lower claims are going to have low dollar, high volume. And you could have, let's say, a $150 claim that's constantly getting denied for a certain service. And you might have 2,000, 5,000 of those, you know, a month or a year or 6 months. And a lot of times those are very easy to resolve. And so you can really get a big bang for your buck on soft costs, because remember, to be taken and, you know, reworked. A lot of organizations and hospitals will have a dollar threshold. So anything that's denied, you know, $100 or less is automatically written off. So that's a lot of money being left on the table if it has a high volume that might not ever get into the world. So take a look at those. Once you've done that, identify 2 to 3 denials to begin with. You're not going to want to tackle everything. It's going to be overwhelming and you feel like you'll never be able to do it, because a lot of these are very labor intensive and take a while to do it. So take 2 to 3. And then your first one you want to start with is something that's straightforward and might be easier to resolve. That'll give you some momentum and some confidence of what you're doing. And so an example of that would be 31, CARS code 31, patient cannot be identified as our insured. And maybe that's something as simple, or not as simple, but retraining registration staff or putting a hard stop in something with the system. Or CARS code 140, patient insured health identification numbers and names do not match. I worked at a pediatric hospital in San Diego at the beginning of my healthcare career, and we had a registration staff member that would commute from Tijuana to work every day. Well, she was registering patients as they handle last names in Mexico, not how it's handled in the US. And we had all these denials suddenly for these mismatch. And it was very easy to resolve. We worked with this particular registration, retrained her on how to do it, and it resolved quickly. So things that we might not think of can be uncovered quickly. All right, now that we've looked at our data and we've identified our initiatives, now it's time for our root cause resolution. So just for the overall process flow, and then we'll get into more detail, we're going to want to start with our current state. What are we doing? What's it like? What's going on? We want to take an in-depth look at our processes and our systems, and then we're going to use that information, data, to define and document our future state. Then we're going to go ahead and work through the project, educate our staff, and then we'll go ahead and implement. And once we have our implementation, a line is drawn in the sand, and now we can compare where we are to where we were. So the current state analysis. It's a really good idea to sit with the staff and observe and document the process. Ask questions, look and see what they do. Review your policies and procedures that these are going to. One of the health systems I worked with in San Diego, we were getting ready for Joint Commission, and so the director's responsibility and managers were to take our policies and procedures, which we wrote and we thought they were wonderful, and sit with the staff and see what they did. It was a very enlightening and eye-opening experience, because what we thought as leaders thought the process was, the staff members hit roadblock after roadblock, so they had workaround. And they would say things like, yes, that's what it says, but this is really what we do. So take a look at those and work with that. And then once that is done, process flow out your current state. So this is just an example of a process flow map of current state. And my top is covered with the screen, but if I remember correctly, it's on a sleep registration authorization for sleep lab. All right, time for your next cartoon, patient registration. Don't you feel like this sometimes? Here's your executive coming to you and saying, we need to streamline our patient registration. I want you to fill out all of these additional forms along with the existing ones, and then enter all the information manually into the patient database. So we feel like we're doing a lot of times. Okay, back to our presentation. So after we do that, we've done our current state. We want to take an in-depth review of our processes and system. Take a look at your EHR or EMR and for the setup, and see if there's potential solutions and optimizations within the system. You'd be surprised of different things when the system was initially set up that wasn't realized, or things had changed and that. Also take a look at your third-party vendor services, provider services, and utilization of those services. We will have I've seen where third-party vendors are in, and leadership believes that the staff is utilizing those services, but the staff is either A, unaware of it, or don't know how to use it, so it's not being done. So take a look at those. I recently spoke with a VP of revenue cycle of a large health system, and he was extremely frustrated. He was having all of these authorization issues, and he would look through the charts, and he had the printout of that it was authorized, and come to find out the vendor had the contract set up incorrectly. So when it went out to authorize, it came back as authorized when it truly wasn't a service that could be authorized. So he had to work with the vendor to reset up their system. So, you know, vendors are not perfect either. So take a look at those, be open to those. And then also explore new technologies and services to increase accuracy. A new technology or service might have been cost prohibitive, you know, 4, 5, 6 years ago, and now it's not so much. And so maybe it can be automated where areas are automatically populated within the system. And that not only increases the accuracy, but it saves time and productivity and will ultimately increase patient satisfaction because they're not spending as much time in during the registration process. Okay, there's a lot on this slide. So we have, after we've done that, we're going to take a look and define and document our future state. So we're going to take a look at our current state analysis and identify areas where we can improve. We're going to pull in with that the review of our IT systems and the issues and concerns, and take a look at the vendor and the vendor process. And we're going to do all of this together and create and document our future state flow chart, right? So once we do that, we now know what needs to be done. So we can create a project plan or a very minimal task list for all items that need to be completed. Some of your projects will take 6 to 9 months. A lot of them are very labor intensive, which will warrant a project plan because you'll have to get other departments involved, maybe IT, maybe billing, maybe clinical. So you'll need to do that. And others might be straightforward that you can work within your department. You're also going to want to review and create new policies and procedures and or update your existing ones. So you want to make sure that your policies and procedures align with your new future state. And then the key here is long-term sustainability. One way to do that is through accountability. So I encourage you to review job descriptions and work with your HR department to see if it's possible to add those type of accountabilities into the employees' job descriptions. Because if they're going to get, if it's going to be part of their annual review and their pay is dependent on it, then they're more likely going to be focused on that particular area and the accuracy. And always, always, you want to make sure that you have your leadership, you've obtained leadership support and buy-in for the project, particularly if it's going to cross departments and it's going to be long-term, so you know that they support it. And then you can calculate your ROI. And calculating your ROI is a webinar in itself, so I'm not going to go through it, but I'll have my contact information at the end. So feel free to reach out to me via email or phone, and I can help you and give you some guidance on that. All right, so here is our sleep study lab, and this is the future state flow where it's going to be. So just an example. So now we've gone through our process, we've completed all of our tasks of our project plan, and it's time for our staff education. And staff education is really, really important. So first you're going to determine who will be doing the training. Does your organization have its own training department or education department, and will they be doing it? How do we get that information? So you'll want to create that staff education plan and then train the staff. And the education plan is important too, particularly in areas of registration where you have people that are 24/7. So you want to make sure that you get your weekend staff and those that work graveyard and make sure that everybody is trained. Once we've done that, we're ready for our initiative implementation. So determine an implementation date. I personally like the first of the month because then my data is very clean, but that's 90% of the time not realistic. So determine what your implementation date is. That's the date that you draw on the line, a line in the sand, and say, as of this date, everybody's training, our root cause has been resolved. Make sure you communicate this to staff and leadership. Leadership needs to know the great work you guys have been doing. And then staff needs to be on board and have buy-in to it. Create staff excitement, you know, have fun with it. Have games, have balloons or boards or whatever that is, gift cards, but have fun with it and create that excitement. That'll help them with the buy-in and make sure that your initiative is successful. All right, the last thing we do is we want to relentlessly monitor. And this should be going around, but it's not. But so let's take a look at the top part of this denial. So we get a denial in, and then typically it goes over to the peachy color, the data. So we get the data in with our 835s, our CARS codes. And then we have a sort of FTE intervention. And then we do a rebill. And then maybe not, somebody will recognize the pattern. And if not, it's on that hamster wheel. Once you've done your initiative, you're going to start monitoring. So now we see a denial. We know that the root cause has been resolved. So if we see it come up, it's going to trigger a monitoring, and we're going to go over and figure out what has happened. And then our action will be taken, and we'll continue with that root cause. So what that does is it moves the intervention, if there's an issue, up front, so you'll have it within a few weeks, a month at the latest, as opposed to waiting for someone to recognize it, which could take 3 months, 6 months. So it's how we have our long-term sustainability. All right. I'm going to do a quick case study, and then we'll open it up for question and answers. So this case study is on eligibility denials. This was from a hospital in Texas. And so their denial was that Patient Access was registering patients with the incorrect insurance, and everybody was frustrated with them. So the leadership took a look at it, and they said, well, you know, the Patient Access staff just doesn't get it. We just need to do more training so that they can determine how to pick the correct insurance. Well, actually, after going through this process and sitting down with the staff and looking and seeing what they're doing and observing, what we found out is that the IT dictionary, insurance dictionary that registration used had not been reviewed or cleaned up since the system went live 10 years ago. Only new insurance plans were added. So what that meant was the registration folks might have had to pick out of 12, 15, 20 different insurances, not knowing which one to pick, and oftentimes just defaulted to the first one. So they put a plan in together, and it took a lot of work. It worked with the IT department and the billing department and Patient Access, and they went through and cleaned up that dictionary. I think it took about 3 or 4 months to do that. And then they went live with it. So, and in addition to going live with it, they implemented an annual insurance dictionary review. So when the contracts were updated, and Blue Cross might update differently than United, so it was whenever those contracts, they took a look at the dictionary to see if anything needed to be removed or anything added. Now, I'm going to give you a word of advice here and caution. If an insurance discontinues, let's say December 31st of 2020, you're not going to want to deactivate that insurance company on January 1st, 2020, because you can still have activity. There's still claims that are going out and processes, denials and that type of thing. In addition, sometimes those dictionaries are attached to reports that are used for cost reports in finance. So I highly recommend taking a look at those. And if they do need to be deactivated, bring them out about 18 months. That'll ensure cost reports are done and any outstanding claims or denials are through the system. So set it with a future date for 18 months in the past. So by doing this, they were able, within the first 6 weeks, to reduce their eligibility denials by over 50%. So it was a huge, huge win on that. All right, Julie, I'm going to open it up for questions and answers. And